Hey everyone, thanks for joining me. My name is Madison Davis, and we're going to be talking about the epidemic of opioid abuse. As a healthcare professional, I'm fully aware of dealing with opioids on a day to day basis, and it can be very serious, and it's really important to dive into this topic. Through this PowerPoint, we're specifically going to be looking at a case study about a postpartum mother. So thank you again for joining, and let's begin. In this first slide, I want to touch base on a quote that really stood out to me as I began my research regarding the opioid epidemic. Dr. Gayer, who is a hospitalist at the Mayo Clinic in Arizona, which is a very reputable hospital, stated that opioid stewardship requires healthcare professionals the understanding of the critical role that they play as the opioid gatekeepers. I'm going to say that again. Healthcare professionals are the opioid gatekeepers. This deeply resonated with me as a nurse, and healthcare professionals, specifically providers, they do play a huge role in the opioid crisis as their prescribers. Referring to healthcare professionals as gatekeepers to this crisis is very eye-opening, and I believe speaks volumes to the responsibility that providers hold in these patients' lives. The opioid epidemic is stealing the lives of many Americans and is lowering the average age life expectancy. In 2017, 1 in 3 people had been prescribed opioids. In 2022, the CDC provided a clinical practice guideline for prescribing opioids for pain in an attempt to get a handle on the epidemic that is taking place. That goes as follows. The first thing that providers should do is check the prescription drug monitoring program. This can be found on the Georgia Department of Health, and prescribers can register there. They should look for multiple prescriber history for each patient, which may suggest doctor shopping. You should watch for the history of other controlled substances such as benzodiazepines or muscle relaxants, which could increase opioid overdose risk. It's important to educate through the risk-benefit discussions with these patients, ensuring that they understand opioid use guidelines. Patients prescribed opioids must know when to take them, what to avoid, such as sedatives and alcohol, and what to monitor for, such as constipation, addiction, and overdose. These patients need to be informed about the importance of locking up opioids to make them inaccessible to others and how to immediately dispose of unused pills. Always pair an opioid with a non-opioid alternative like Tylenol or ibuprofen around the clock to reduce the need for the opioid. Non-pharmacologic therapies such as physical therapy, daily exercise, heat therapy, and massage therapy can be used as adjuncts. Avoid opioid use for chronic or undifferentiated pain. If patients required opioid therapy beyond 45 days and don't have symptom improvement, then you should consider referring them to a pain management specialist. You should also always offer these patients Narcan to go home with, just in case they do have a history of breathing problems, kidney or liver dysfunction, or even substance abuse disorder. It's a good thing to have on hand. Develop rapport with the patient. Dr. Gayer says she feels like the best opioid addiction prevention strategy is to have a complete, open, and honest relationship with the patient. Here you can see that I have a little chart that shows the pathway of pain perception. To explain it in easy terms, basically pain warns the body of disease or injury, and the nociceptor neurons play a key role in the pain and inflammation process. Interactions between the nociceptors and the immune system occur both at the site of injury and within the central nervous system. Basically, the sensory nervous system is essential for modulating the body's protective response. This makes it critical to understand these interactions to discover new pain treatment strategies. Pain is a vital defense mechanism for the body, and it is important to understand the pathophysiology of pain to yield improved pain management. This is something extremely important for providers to understand, since they are the ones who are the gatekeepers to pain management. The next thing that I really want to touch base on is pharmacodynamics and pharmacokinetics. Pharmacokinetics is what the body does to the drug, how the drug is absorbed, where it's absorbed, and how does the body handle the drug. Pharmacodynamics is what the drug does to the body, which basically means what changes in the body after the drug is given. The pharmacology of currently available prescription and illicit opioids is complicated because no drug targets a specific opioid receptor or is entirely free of tolerance, dependence, and physical withdrawal. The development of an opioid use disorder is generally preceded by prolonged or increasingly higher dose use of an opioid, which ends up leading to tolerance and dependence. However, profound modulation in specific brain areas shows that it affects a number of neurotransmitters, but it's not always observed in those who develop tolerance or physical dependence to an opioid. Amid a continued crisis in opioid overdoses and increased prevalence of overdose-associated deaths, the opioid epidemic continues to impact millions of Americans and others around the world. Because of the euphoric effects and the high risk of dependence, opioids have a high risk of abuse and addiction, which then complicates the therapeutic use in the treatment of acute and chronic pain conditions. It's important to have considerations to shape the misuse of an opioid in the past 2 decades. You can consider the half-life, the potency of the opioid, and in some cases, its ability to activate the dopaminergic reward pathways for longer periods. Many of the emerging illicit structures with potent opioid activity remain poorly studied and do require further investigations in regards to the specific pharmacological effects and toxicity. So basically, we know that there's a problem, but there does need to be continued research into the pharmacodynamics and the pharmacokinetics of opioids. The CDC is committed to addressing the opioid overdose epidemic and supporting states and communities as they continue to work to identify outbreaks, collect data, respond to overdoses, and provide care to those in their communities. On average, 217 people died each day from an opioid overdose in 2023. Statistically, almost 80,000 people die per year due to an overdose on opioids. And then in 7 out of 10 overdoses, opioids are the root of the cause. Over 1,800 people died from an opioid overdose in the state of Georgia. And then specifically in Rome, Georgia, according to the Rome News Tribune, which is a reputable newspaper in Rome, Georgia, the Northwest Georgia has been identified as having one of the most severe opioid crises in the state. With the Northwest Georgia Health District, which covers 10 counties, which refers to Bartow, Catoosa, Chattooga, Dade, Floyd, Gordon, Haralson, Paulding, Polk, and Walter County. Through this district, it reports that we had the highest 5-year opioid overdose death rate of Georgia's 18 public health districts. The good thing is that there are resources for those who use or abuse opioids. The first one that I want to talk about is the 988 Lifeline, which is a national mental health hotline that is 24 hours, 7 days a week, and it's a service to anyone who needs it. A quote from their website states, "At the 988 Suicide and Crisis Lifeline, we understand that life's challenges can be sometimes difficult. Whether you're facing mental health struggles, emotional distress, alcohol or drug concerns, or if you just need someone to talk to, our caring counselors are here for you, and you are not alone." You can literally go dial 988 on your phone and talk to any of these people and get the help that you need. There's another place locally to Rome, Georgia, known as Southeast Detox, which is used for medical detox and residential treatment. Per their website, it says that detox becomes necessary when withdrawal is expected to be medically risky, intensely uncomfortable, or difficult to manage without supervision. People who use substances daily have trouble stopping on their own or have experienced withdrawal symptoms in the past, which often do require medical oversight. Those with co-occurring mental health conditions or a history of relapse also do benefit from a structured detox environment. Alcohol, benzodiazepines, opioids, and certain prescription drugs can lead to severe withdrawal symptoms, which makes at-home detox not only difficult but potentially life-threatening. A professional detox center ensures safety, comfort, and stabilization from the moment that withdrawal begins. I want to identify 2 challenges related to the adequate treatment of pain. The first one is the fear of addiction when prescribing, and this is coming from the provider. And the second one is the bias and disparities between patients. In a study by Melody Chavez, she focuses on a cancer patient's view of opioids. She found that there was even fear of addiction when prescribing opioids to cancer patients, which led to decreased pain management. The thematic analysis revealed that cancer patients view opioids as an illicit drug. Media narrative of the opioid epidemic increased the negative perception of opioid use for their cancer-related pain. The perceptions of opioids were also informed by experiences of friends and family with an opioid use disorder. Poor understanding of terminology did result in misconceptions of opioid use and addiction, and the fear of opioid addiction resulted in unrelieved cancer pain and the poor quality of life. So that goes for the fear of addiction when prescribing. And then socioeconomic factors such as race, ethnicity, education, and cultural values also shape care delivery in rural environments. A study on pain management in Alabama found that rural populations are more likely to be unemployed, have higher poverty rates, and lower literacy rates compared to urban residents. Black and African American patients with low literacy reported higher pain intensity and greater interference with daily tasks. Other research has found that Black and Hispanic patients continue to be prescribed fewer opioids and analgesics regardless of their pain. The rural patients were also found to treat themselves first and were more likely to hold stigmatized views of organized care instead of placing a higher value on personal autonomy. Black and African Americans had decreased access to pain clinics, and cultural values often favored self-reliance over medical intervention. The distrust in healthcare arose from a lack of transparency in healthcare decisions and poor communication about self-treatment choices. So personal biases and disparities amongst patients can be a huge challenge to adequate treatment of pain. If you made it to this part of the PowerPoint, I want you to close your eyes, put on your scrubs, and let's go to the bedside, and we're going to do a bedside shift report on the maternity unit. The patient that I'm going to be giving you, her name is Miss Davis. Her date of birth is 3/28/1998. She's a G1P0, delivery time 10:06. She delivered a baby girl at 39 weeks and 5 days, and she did have an epidural. Unfortunately, she did have a third-degree laceration, which was repaired after delivery. She does have an IV. It's a 20 gauge in her right forearm, and her quantitative blood loss was 275 after delivery. She's rubella immune, Hep B negative, GBS positive, and she was treated in pre and post labor. It is now 1600 during your shift, and you complete Miss Davis's final fundal check. Her last bag of Pitocin is finished. Her fundus is one under the umbilicus, and her bleeding amount is small. She is not having any blood clots. She has complete filling of her legs after having an epidural taken out around 10:30 this morning. Her Foley catheter was removed around 1300, and she is supposed to pee within 6 hours of her Foley being removed. She ambulates to the bathroom well and voids. Afterwards, she completes pericare. She is complaining of pain and burning in her vagina. How can we help her, and what can we do to assist her with her pain? Before we jump into how to treat her pain, we need to know what kind of pain that she's experiencing. The kind of pain Miss Davis is experiencing is somatic pain. You know that it's somatic pain because of the characteristics. It's localized to one area, which is specifically the vagina, and this pain is caused by the trauma of giving birth. Somatic pain can be described as sharp, aching, sore, or even feeling like a burning sensation, and a couple of those are on Miss Davis's symptoms that she describes. Upon assessment, you do note swelling, redness, and slight bruising of the perineum when helping with pericare. What kind of non-pharmacologic interventions can we do for her before we even consider any type of medications? There are a few non-pharmacological interventions that can be considered. The first thing that I would do for Miss Davis is after we perform pericare, I'm going to give her an ice pack to place directly on the site. On top of the ice pack, I might even add Tux and Dermaplast. Both of these things can decrease swelling and inflammation and provide localized pain relief by cooling the area and soothing any potential burning sensation. You can also do sitz bath maybe on day 2 and 15 to 20 minute sitz baths can also help decrease the swelling and the inflammation. So alternating the sitz bath and the ice packs can really help with the area. Another thing to consider is a waffle cushion. If she's sitting up in the bed, she can be putting a lot of pressure on her bottom. So a waffle cushion will decrease the pressure, and which that will lead to decreased swelling and inflammation. In a concept analysis by Layla Ganbari Afra, analyzing Watson's theory of human caring, and a study has referred to kindness, empathy, concern, and a love for self and others as features of human caring. Non-pharmacological interventions are the first line of a treatment for a postpartum mother. These things directly treat and improve inflammation in the area of injury, and when these things are not working, you move to medications to help with the pain. Postpartum care is extremely delicate and is such a vulnerable time of a new mom's life. Jean Watson's caring theory can be applied to postpartum nursing as it requires kindness, empathy, and understanding. Each birth is different and each person's pain tolerance is different. And as a nurse, it's important to remain unbiased and to provide the best compassionate care for each person and make sure that it's tailored specifically to those people's needs. Something as simple as just giving a mom an ice pack lets you know I'm thinking of you and I'm thinking of you specifically, and I know that you're in pain, and I'm not just going to give you medicine. Let's do all the different things that we can. If we have to do 5 different things to help provide you with some pain relief, then we're going to do it. And that makes them feel happy and lets them know that they're being taken care of. Typically, the beginning of pharmacological interventions begins with Tylenol and ibuprofen alternating. The usual dosage for ibuprofen is 800 milligrams every 8 hours, which works on decreasing the inflammation in the body. And then you alternate it with 1,000 milligrams Tylenol, which is given every 8 hours. So we know every 4 hours we're given something to treat pain and inflammation. If that is not controlling the patient's pain, then opioids would be the next line of treatment for severe pain. The main medications administered to postpartum moms is oxycodone and hydrocodone, which are also both safe while breastfeeding, which is something to consider when prescribing opioids. To round out this PowerPoint, I want to say that specifically postpartum pain management does require an individualized approach and consideration to any potential birth trauma that has taken place. For some patients, they have an easy delivery with no tears, while other patients have third-degree tears, and other patients end up having to have C-sections. With the scenario that I provided, it is okay to prescribe opioids short-term, but this is not a long-term solution to the pain being experienced. Non-opioid medications are great options for these patients, and they're less addicting. It's also important to be sure that non-pharmacological interventions are taking place. As a nurse, we are responsible for making sure that these patients feel comfortable, that they feel safe and taken care of. We can promote healing by repositioning, by providing the ice packs, by checking in and saying, how can I make your pain better? What can I do for you? As a nurse, we are responsible to perform accurate pain assessments, promote healing, and to care for the patient as a whole. This doesn't only just apply to postpartum mothers. It really does apply to all patients we care for as nurses. So thank you all for watching my PowerPoint, and I hope that going forward that you think of, as a nurse, you're not the one who's going to be prescribing the medications, but what can I do to make these people's pain better that are taking opioids to decrease their chances of continuing to need the opioids. Thank you. Have a good day.